A very good morning and a warm welcome to all of you. I'm Dr. Rajalakshmi and I'll be giving you an overview of orbital cellulitis. Of all the orbital diseases, inflammation, that is thyroid, is the most important. Out of all the inflammations, the infectious causes contribute to 20%, around 20%. But still, though rare, we are discussing about orbital cellulitis because it is a potentially vision-threatening and a life-threatening disease. And in this presentation, I'll give you an overview of the etiology, the different presentations, what you should look for, the microbiology, imaging, the classification, and management. So, orbital cellulitis is more common in children less than 9 years of age. And among children, study from India has shown that it is seen in around 9.29 cases per 100,000. And there is a slight male preponderance in the pediatric age group, but the reason for this is unknown. Cellulitis peaks during the winter season, correlating with the increased incidence of upper respiratory tract infection and sinusitis. And there is also some socioeconomic influence in the form of overcrowding and access to healthcare, poor access to healthcare, which increases the incidence in developing countries. With the increasing use of vaccines, the influenza-related cellulitis has come down. Now let's just quickly review the anatomical factors that predispose the orbit to these infections. The first thing is the orbit is surrounded on all sides by the, or rather 3 sides by the sinuses, superior, medial, and inferior. And also the orbital bones, especially the medial wall, is very, very thin, lamina papyracea. There are a lot of orbital foramina which communicate in and out of the orbit, as well as the valvulus, veins, and the lymphatics. All these predispose. In addition, in children, there is an immature immune response. So all these predispose the orbit for infections. So how do the infections reach? The etiology, the most important is from the contiguous, the neighboring structures, namely the sinuses. Of course, it can also spread from preseptal, as Madam explained, and infect the complication of dacrocystitis. Injuries, either directly or after surgery, can inoculate the organism into the orbit. So look for post-op complications of eyelid, orbital, or dental or sinus surgeries. Hematogenous spread, especially the dental infections from the upper molar through the maxillary sinus, can spread into the orbit. And inoculation into the orbit through hematogenous spread happens in conditions like endocarditis, especially in debilitated or immunocompromised hosts. In the post-COVID, we have seen a rise in fungal infections. In children, it is usually monomicrobial, that is, the infection is by a single organism, with Streptococcus pneumoniae and Staphylococcus being the most common organisms. And we have noted that with the increasing use of vaccines, influenza-related infection has come down. While in adults, it is mostly polymicrobial. We also see MRSA increasingly in adults, as well as the anaerobes and gram-negative rods. In immunocompromised, especially, as I mentioned, in diabetics, post-transplant patients on steroids for long-term, and as well as in post-COVID period, we saw a surge of fungal infections, especially mucor. So most of these infections are around 80% are found to be bacterial in origin, and around 5 to 6% is fungal. So let's focus more on bacterial orbital cellulitis. The earliest clinical presentation would be a lid edema and erythema, which is not going to help us to differentiate a preseptal from orbital cellulitis. Look for signs of, or a red flag rather, a proptosis with a globe displacement, which will tell you the direction if there is a collection inside the orbit. Look for ophthalmoplegia and visual signs like diplopia or RAPD and color vision loss. If you identify bilateral or see bilateral features with cranial nerve palsies or altered mental status, it means the infection has spread posteriorly and intracranial extension should be suspected. The Chandler's classification helps you to grade the severity of the disease, starting from preseptal cellulitis, where the infection is in front of the septum, there is only inflammatory edema. The orbit is not involved. The second stage is where you have a diffuse cellulitis with the post-septal edema and infiltration. The third stage and the fourth stage is where there is a localized collection within the orbit, where you have a subperiosteal abscess between the bone and the periosteum, or a collection within the muscle inside behind the globe, where these will result in severe symptoms. The last one would be posterior extension into the cranial cavity with cavernous sinus thrombosis. CT is essential to make this classification. Jain and Rubin suggested another simplified classification where they have divided this disease into 3 stages. The first one is a preseptal cellulitis. The second one is orbital cellulitis with or without intracranial complications. The third one is abscess. Again, it can be intraorbital or subperiosteal with or without intracranial complications. Now, what is the role of imaging? Imaging is very important as it is going to help us differentiate orbital cellulitis from preseptal cellulitis. Not only that, it is going to help us to detect the complications, to assess the severity of the disease, as I told you. So the extent of involvement, the size and the location of the abscess, the coexisting sinus disease, and the intracranial extension can be identified by this. You all know CT is the first line. It is available easily, it is fast, and best suited to identify the abscess and sinus pathology. MRI is most suited for detecting the soft tissue involvement and intracranial spread. Ultrasound, not of much use, but maybe in children, as well as it can help in guided aspiration of more anteriorly located abscesses in the orbit. So imaging is going to help us guide the surgical management. So this is the Chandler's classification that is shown in this imaging. So in the first picture, you can see there is a involvement in front of the septum, soft tissue involvement in front of the septum, which is stage 1, preseptal. The stage 2, where there is a diffuse fat standing and inflammatory edema within the orbit. The stage 3 and 4 show localized rim enhancing collection. This is a subperiosteal abscess. You can see, note the adjacent ethmoidal sinusitis with mucosal thickening. The intraorbital abscess collection within the orbit. The fifth one is the cavernous sinus thrombosis, though MRI would be better suited for this. It will show filling defect. So let's quickly see what lab workup we need to do. Do a complete blood count. It is going to show neutrophilic leukocytosis, especially in bacterial cases. CRP, ESR are going to be elevated in any case, but it may help in detecting the response to therapy. Complete with a blood glucose HbA1c. Blood cultures are to be done before starting any antibiotic. Though they are of low yield, in moderate to severe cases with systemic symptoms, you may get positive results, and it may help you guide the treatment if there is a need to change the treatment. Microbiological sampling from sinus aspirates and nasal swabs may not be of much use, but they may help you in chronic diseases. They may help you to identify the organism. However, definitive would be an aspirate from the orbital abscess. Moving on to management. So the first thing that we should remember is, once the clinical suspicion has been made, immediately we should start the patient on therapy. A prompt initiation of empirical IV antibiotics is critical to manage a case of orbital cellulitis. So we have to start the patient on broad spectrum antibiotics. And remember, it is a multidisciplinary approach because there is a need to treat the underlying predisposing factors. Not only that, we need to closely monitor the patient for visual acuity, pupillary response, motility, and systemic symptoms. So this is the table that gives you the management that is usually followed for pediatric and adult cases. The first line would be ampicillin sulbactam in pediatric cases, while it is third generation cephalosporin preferably in adults. For MRSA and anaerobic coverage, vancomycin and metronidazole are used both in both the groups. The dose needs to be adjusted for children. The duration of therapy is usually around 2 to 4 weeks. The first 2 weeks would be an intensive IV antibiotic, and if response is seen, can switch over to oral antibiotics. So the oral step-down option would be amoxiclavulinate for both the groups. The duration and monitoring need to be done for both the cases with vision, motility, extraocular motility, fever, and in addition, in adults, you need to control the systemic source as well. Now, steroid use is controversial. Low reliability has been shown in a Cochrane review, and while some observational studies have shown that use of steroids after 48 hours of antibiotics has shown some improvement by reducing the inflammation and hospitals. Basically, the colors, I'm sorry for the colors, it is supposed to be like a traffic signal. It is green, yellow, amber, and red. So when you see a well-controlled disease with good response to antibiotic, steroids can be used cautiously. The second one is pause, reassess the patient. If you're going to start steroids with a borderline subperiosteal abscess, a mild globe displacement, but there is no threat to vision. In case of RAPD, vision loss and abscess, it is a red signal. Do not start the patient on steroids. So when do we go for surgical intervention? Surgical intervention is needed for drainage of subperiosteal abscess when it is more than 10 mm, when there is a rapid vision loss or RAPD, especially in lateral or a superior abscess, because it is unlikely to resolve on its own medically. And if you do not see a response to treatment after 24 to 48 hours, not only for draining the orbital abscess, to treat the sinus surgery as well as intracranial complications also, we need to surgically intervene. The complications will be dealt in detail by the subsequent speaker. So this is an overview of the different stages of orbital cellulitis, and just to quickly tell you how to manage the case. So the first stage is preseptal, where there is only inflammatory edema with normal orbital findings. Start the patient on oral or IV antibiotics as per the severity. The patient can be treated as an outpatient. In case of pain, proptosis, and motility restriction with orbital cellulitis stage 2 and imaging shows a diffuse orbital fat stranding, patient needs to be admitted, started on IV antibiotics, and monitor the patient closely. The stage 3 is when there is a subperiosteal abscess with a localized limb-enhancing collection seen and a globe displacement. In addition to IV antibiotics, consider surgical drainage if the criteria for drainage are fulfilled. A case of orbital abscess with severe proptosis, ophthalmoplegia, and an intraorbital collection needs urgent surgical drainage along with IV antibiotics. And with cavernous sinus thrombosis, where you see bilaterality, multiple cranial nerve involvement, and systemic deterioration, patient needs ICU care with IV antibiotics and anticoagulation. A few points to consider when dealing with children and adults. In children, ethmoiditis is the common source because of the thin lamina papyracea. So the most common organisms are Streptococcus and H. influenza. And they do have a high threshold for surgical drainage. They can be managed medically successfully. And in case of adults, they have a complex source of infection. It can be either from trauma or dental infections can spread in addition to sinusitis. They usually have a polymicrobial with anaerobes and MRSA as a causative organism. The surgical threshold is lower, meaning early drainage may be required, and they do have more systemic toxicity. So the take-home message, orbital cellulitis is an diffuse inflammation of the orbital soft tissue behind the septum with potential vision and life-threatening complications. There is a need to recognize early, as delay may cost vision or life. Image smartly. First line would be a CT. If suspecting intracranial complications, go for MRI. Treat fast. Don't wait for the culture report. Start the patient on empirical therapy, broad spectrum, and train decisively. Pediatric and adult presentations differ. Tailor the management accordingly. These are my references. Thank you.